Welcome to the EO podcast series on metastatic renal cell carcinoma. In this last episode, we are joined by Andrea Mari, a urologist at Chiara University Hospital in Florence, Italy. Also Chiara Ciccarese, a medical oncologist in the Department of Medical Oncology and Comprehensive Cancer Center at Agostino Gemelli University Hospital in Rome, Italy. Together, they will discuss beyond first-line treatment strategies for metastatic renal cell carcinoma. Join us as we embark on this informative journey.
Hello and welcome to our podcast. My name is Andrea Mari, and today we will discuss the sequencing strategies for the treatment of advanced renal cell carcinoma, with a special refer to patients who are not responding or have recurrence after first-line treatment. Today, I'm honored to have Dr. Chiara Ciccarese, who is a medical oncologist at the Gemelli Hospital of Rome and expert in genitourinary tumors, mainly in kidney cancer.
Thank you, Andrea, for having me. It's a pleasure to be here.
In today's practice, managing metastatic RCC has greatly improved by using target therapies and immunotherapy. We are seeing impressive results from new frontline immune-based treatment, such as Nivo plus Ipi, pembrolizumab with axitinib, nivolumab plus cabozantinib, and the combination of lenvatinib and pembrolizumab.
Yeah, the latest findings from ASCO GU 2024, particularly the updated results of the Checkmate 214 trial with 8 years of follow-up, which is the longest follow-up among trials involving immune checkpoint inhibitors for advanced renal cell carcinoma. They reinforce the advantage in overall survival of nivolumab plus ipilimumab in patients with intermediate and poor risk renal cell carcinoma with long-lasting responses. From the other side, combinations of VEGFR TKI plus immunocheckpoint inhibitors are also associated with a significant increase in patients' survival outcomes, regardless from the IMDC risk groups, with an impressive disease control rate, percentage of primary refractory slightly exceeding 10%, comparing to about 1/4 with nivolumab plus ipilimumab, and complete responses reaching 11% of cases.
Yes, Chiara, I agree with you. These data are really impressive. While we have made great advances with first-line treatments for metastatic RCC, at a certain point, patients unfortunately progress, which underscores the need for effective second-line therapies. So the good news is that we have several approved options, giving us more tools for treatment. What do you think about it?
It is quite obvious that the change in the first-line strategies has had repercussions on the second line. There is still much to learn. We are working with limited, mostly retrospective data here, as the evidence is particularly scarce for patients who do not respond or progress the initial immune checkpoint inhibitors-based combinations. Actually, we have little evidence for second and even less for subsequent lines of therapy. The good news is that several prospective trials are ongoing.
So, Chiara, in your opinion, which is the current strategy in patients who progress after first-line IO combos? Do you think there may still be a role for immunotherapy?
Well, if you think about immunotherapy as monotherapy, we have data from 4 randomized controlled trials, Titan RCC, Omnivore ICC, the ACRN-GU 16260 fraction study, which investigated an intensified approach of adding ipilimumab in case of disease progression or no response to nivolumab monotherapy. All these trials do not support a response adaptive strategy for anti-PD-1 CTLA-4 inhibitors. Similarly, retrospective analysis of immunotherapy rechallenge suggested only limited activity.
Okay. So your conclusion is no IO after IO. I do suppose that VEGFR TKI therapy represent the best second-line option. But the question is, which one?
Exactly. After nivolumab plus ipilimumab and VEGFR TKI plus IO combos, a VEGFR TKI has the strongest evidence as for now, with objective response rate ranging from 20 to 50% and median PFS of about 6 to 13 months in various retrospective analyses. Compared to the others TKI, cabozantinib is associated with higher objective response rates and median PFS that is almost doubled, but these data are retrospective and therefore with many limitations. Recently, after small prospective phase 2 trials investigated the activity of second-line VEGFR TKI, either sunitinib, axitinib, or cabozantinib, post-immunotherapy, showing objective response rate ranging from 20 to 45% and median PFS from 5.6 to 9.3 months. In particular, the Breakpoint phase 2 single-arm Italian trial enrolled 40 metastatic RCC patients progressed to a prior in IO-based treatment to receive cabozantinib. This trial showed a median PFS of 9.3 months and an objective response rate of 43% with additional 37% of stable disease. A similar trial presented by Laurent BGS at the last ESMO, the CaboPoint trial, a phase 2 single-arm study, included 2 cohorts of patients. Patients progressed after nivolumab plus ipilimumab, cohort A, and patients progressed to a combination of VEGFR TKI plus IO, cohort B, but all of the patients were treated with second-line cabozantinib. This study showed an objective response rate of about 30%. Of note, the response rate in patients progressing to nivo-ipi was even greater, reaching 40%. And what is important to notice was that cabozantinib was also active in patients refractory to first line. That is to say, those patients with a median PFS of the first line shorter than 6 months. Cabozantinib reached an objective response rate of 34%.
Okay, Chiara, thank you very much for summarizing all these impressive results. So my question now is, what about patients who progressed to first-line nivo cabozantinib?
This is the most challenging field. I would say that another VEGFR TKI should be used. The main concerns regard which TKI, sunitinib, axitinib, which one can overcome the resistance to cabozantinib. I think that a potential interesting option would be the combination of lenvatinib plus everolimus, even though there is only little evidence on its efficacy after IO combos, and in particular after cabozantinib.
Okay, so we see that continuing or intensifying immunotherapy has failed, and that regardless of the type of immune-based combination used in first line, the strongest data are in favor of a second line with VEGFR TKI. If therefore comes naturally to me to ask you if the possibility of adding immunotherapy to TKIs also in second line has been investigated.
For sure, it has been. 2 similar studies, CONTACT-03 and TiNivo-2, were designed to answer at the question whether the doublet of IO plus VEGFR TKI in second line could increase patients' outcome compared to a VEGFR TKI monotherapy. Unfortunately, the results of the CONTACT-03 were negative. The addition of atezolizumab to cabozantinib did not result in a prolonged PFS or OS compared to cabozantinib monotherapy in patients who progressed on or after a prior immune checkpoint inhibitor. The subgroup analysis of this trial did not identify any subset of patients who might benefit most from this combo, and furthermore, increased toxicity was observed in the experimental arm. So actually, the anti-PD-L1 used in this trial, atezolizumab, was not the best choice, but we are waiting for the results of the TiNivo-2 study, which randomized patients to the combination of tivozanib plus nivolumab compared to nivolumab monotherapy. I think that the results of this study will definitely state whether adding or continuing better immunotherapy in second line is really needed or not.
Okay. And so at ESMO 2023, Professor Chouiri presented the results of the LIGHTSPARK-005 trial of belzutifan compared to everolimus for pretreated metastatic renal cell carcinoma patients, and the drug received the FDA approval. Do you think there could be a role for belzutifan in second line?
So belzutifan is a first-in-class inhibitor of F2 alpha. It demonstrated a statistically significant, albeit I would say clinically doubtful, improvement in median PFS compared to everolimus. In a cohort of heavily pretreated metastatic RCC patients, only 10% were in second line, more than 85% in third or fourth line of treatment. No overall survival advantage was observed. So as for now, we know that approximately 90% of sporadic renal cell carcinoma present inactivation of VHL that leads to a state of pseudohypoxia that in turn translate into an overexpression of F2 alpha, which regulates various oncogenes related to proliferation, angiogenesis, and immune escape. So belzutifan targeting F2 alpha inhibits the angiogenesis at a transcriptional level. In my opinion, the most interesting strategy is the one that combines belzutifan to a VEGFR TKI that inhibits the angiogenesis at a receptoral, so a peripheral level. A prospective phase 2 study, the MK011, is ongoing. It has ended the enrollment of patients with the aim of evaluating the combination of belzutifan plus lenvatinib versus cabozantinib in second line of therapy.
Okay, thank you, Chiara. These results are really impressive. So let's make a step forward. In your opinion, what are the recommendations we can make for a patient failing after the second line treatment?
I would answer enrollment in a clinical trial if available. Actually, the current EAU guidelines recommend sequencing the agent not used as second line therapy. This means everolimus or belzutifan if available, or a VEGFR TKI not previously used for third line of therapy.
Thank you very much for sharing your insight and for your time. I would like to thank all our listeners for joining us today. This last episode of the series of Metastatic RCC of the EAU podcast. I really hope that our discussion has provided a better understanding of the latest developments strategies for better managing metastatic renal cell carcinoma. Thank you.
Thank you too.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.